I welcome you again in the last session of pathology. We all are honored again since it's very early in the morning in the US and it must be 5:40 in the morning. And even at this time, Dr. Parwani does not have any hesitation to deliver his lectures. In this session, we have two lectures of Dr. Anil Parwani. And for those who could not join us yesterday, I can introduce Dr. Parwani again. He is professor of pathology at the Ohio State University. He serves as the vice chair and director of anatomical pathology, pathology informatics, and director of digital pathology. Moreover, he has expertise in biobank informatics, clinical and research data integration, application of whole slide imaging, and telepathology. His research is focused on diagnostic and prognostic markers in bladder and prostate cancer and molecular classification of renal cell carcinomas. Dr. Parwani has authored over 300 peer-reviewed articles. He is editor-in-chief of Diagnostic Pathology and one of the editors of Journal of Pathology Informatics. His first lecture would be recent advances in pathology and molecular genetics in urothelial carcinoma and adenocarcinoma. And while the second lecture would be recent advances in prostate pathology 2020. Now over to Dr. Anil.
Thank you so much. I want to thank the organizers. I want to thank Dr. Hussain for moderating this session. Looking forward to speaking to you today about bladder cancer updates and prostate cancer updates. So in the first talk, we're going to talk about pathology of urothelial carcinoma and adenocarcinoma from the bladder. Can you see my screen?
Yes.
Okay, so we're going to get started. So what I'd like to do today is talk to you about the current understanding of the molecular pathology of urothelial carcinomas. I want to give you an overview of the 2016 WHO classification. I want to show you some variants of invasive carcinomas, and I'm going to talk to you about how can immunohistochemistry help us in diagnosing and classifications. And if we have time, I can give you some cases, but let's get started. So urothelial carcinoma is one of the most common tumor of the bladder. This cancer has a propensity for divergent differentiation. So you can see squamous carcinoma differentiation, glandular differentiation. It's important to recognize these variants because they can mimic benign lesions, they can mimic cystitis cystica, glandularis, inverted papillomas, paragangliomas, nephrogenic metaplasia. And we're learning more and more about these tumors. We're learning more and more, getting more insights into these subtypes, and this can have a huge impact on how these patients are treated. So the current classification separates urothelial tumors into infiltrating versus non-invasive urothelial carcinoma. So these are some of the variants: nested, microcystic, micropapillary, lymphoepithelioma-like, plasmacytoid, and others. And there are several non-invasive lesions. So carcinoma in situ, non-invasive low-grade carcinoma, non-invasive high-grade carcinomas, tumors with low malignant potential, the papillomas, inverted papillomas. So this is how we currently classify these tumors. These used to be called papillary versus flat, but we no longer use that terminology. So once again, these are the non-invasive lesions, and these are the invasive lesions. And you can see there are multiple variants which are now recognized by the WHO. So when we look at the previous classifications, the 1973 classification and 2004, these used to be called low grade versus high grade, or grade 1, grade 2, grade 3. We no longer use this type of classification. So it's easy to think of dividing them into non-invasive tumors versus invasive tumors. So when we talk about invasion, it's important to recognize what are some of the key features of invasion. So here we can see in this panel early invasive urothelial carcinoma. So very superficial disease, T1 disease. The invasive nests have a very prominent desmoplastic reaction, and these foci of tumor cells within the lamina propria, you can see some retraction artifact here. When you're also reporting in your pathology report if the tumor invades into muscularis propria or not. So now let's talk about what we know today about the molecular pathology of urothelial carcinomas. So many of these tumors have now been sequenced. So we can think of this in normal urothelium in two different pathways. So normal urothelium becomes hyperplastic, gives rise to low-grade carcinomas, which keep recurring biologically. In these tumors, there is a mutation in RAS and FGFR3, or overexpression or mutations. But these tumors are generally genomically stable. Patients, biologically, they will come back with the tumor on follow-up, and these keep recurring. On the flip side, there are tumors which go to the dysplasia pathway and become carcinoma in situ. These have a lot of these tumors have a deletion or mutation in P53, RB, or they have a loss of heterozygoity in P10 or mutation. And these tumors are more genomically unstable. A subset of these low-grade tumors can become high-grade. They may recur, or they may again go into this invasive pathway. So this is what we currently understand. And these tumors have now been sequenced, and we can actually classify them into different clusters. So this is the work that was published by the TCGA project, where many of these tumors were sequenced. These included non-papillary tumors. So here you can see these different clusters. And if you want to look at it even deeply, there are three different clusters to think about. Cluster 1 and 2 are these tumors with papillary morphology, have the FGFR3 mutations or high FGFR3 expression. So they have a luminal breast-like tumor profile, and they express CARA3 and HER2-neu. Cluster 3 is more basal squamous-like. So these are tumors which look like the squamous cancers of the head and neck and lung. And these tumor markers express keratin 14, keratin 15, keratin 6A, and EGFR. So how does that help oncologists treat these patients? So when you think about the different normal bladder mucosa and you look at the pathway that we discussed, and you look at these different clusters, so papillary morphology, cluster 2, cluster 3, all these have different subtypes. So the luminal papillary subtypes, the luminal invasive subtype, the basal squamous subtype, or like neuroendocrine type subtype. All of these have different types of treatment, particularly the immune checkpoint inhibitor, the PD-L1 positive tumors. So we've learned a lot about these tumors, and there are also, I want to talk to you about today, glandular lesions of the bladder. So the glandular lesions of the bladder include cystitis cystica, nephrogenic adenoma, mullerianosis, villus adenoma, urachal cancers, and clear cell adenocarcinomas. So this is a nephrogenic adenoma. This looks concerning. Like if you look at this picture here, this looks like this could be invasive adenocarcinoma. But this is a benign reactive type of a lesion. It's thought to arise in the kidney. And if you, like some of these can look very, very scary and look very alarming. This looks like cancer. They have some degenerative type atypia, some hobnailing. If you stain these with CK7, they will stain strongly. And they can have a papillary type morphology also. So this is a benign reactive lesion. You can see some inflammation. You can see neutrophils here. So again, they can look very, and to the urologist, they can look like a tumor. So let's look at the adenocarcinomas, primary adenocarcinomas of the bladder. There are two general types, urachal, which arise from the urachus, or those arising from the bladder itself. There are several morphological patterns such as the enteric, signet ring, mucinous, hepatoid, or mixed. But the key thing is it's more common to have a bladder adenocarcinoma which is metastatic from somewhere else rather than primary adenocarcinoma. So if you're making a diagnosis and you want to call it primary bladder adenocarcinomas, make sure you exclude all possibilities that this is coming from somewhere else. So this is a villus adenoma of the bladder. It's histologically identical to colorectal adenomas, which has a villoglandular architecture, fibrovascular cores, which are lined by columnar epithelium. Invasive cancers of enteric type may arise from villous adenomas. So these are some examples of adenocarcinomas of the bladder. Again, it's very rare to have a primary bladder adenocarcinoma, and more likely when you're making the diagnosis, it's more likely it's coming from somewhere else. Most commonly, these patients have hematuria, they have a poor prognosis, and again, you have to distinguish primary bladder adenocarcinomas from urothelial carcinoma with glandular differentiation, which may occur. So you can see glandular spaces within a urothelial component, but you have be careful not to call this adenocarcinoma because the molecular biology is very different, the pathways are very different, and the treatment is very different. So some of the tests that can be helpful is CK20 is positive, CK7 may be positive. They may express the GI markers like Villen and CDX2. But if you looked at beta-catenin immunostaining, these primary bladder adenocarcinomas tend to be negative for nuclear beta-catenin expression. So these are some examples of adenocarcinoma of the bladder, more well-formed malignant glands. This is more mucinous type, so you can see lakes of mucin with signet ring cells in the pools of mucin or glands in the pools of mucin. And again, they stain strongly for CK20, and they can express CDX2, which is what you would see with a colon cancer. So it's really hard to distinguish primary bladder adenocarcinoma from a metastatic colon cancer. But again, you can see in this case we did beta-catenin staining, and you don't see any nuclear expression. In the colon adenocarcinomas, you will see nuclear expression of beta-catenin. So that may be a useful marker. So we went forward and we sequenced a bunch of these primary bladder adenocarcinomas. So I'm going to show you today 15 well-characterized primary bladder adenocarcinomas. And we used next generation sequencing, and we looked at mutations and copy number changes in these tumors. We also scanned and sequenced high-grade urothelial carcinomas and 25 colorectal carcinomas for comparison. So in this study, we had 10 males, 5 females. Tumor size was 4 average, and there were 9 enteric types, 3 mucinous types, some signet ring types, and this ranged in PT staging from 1 to 4. But the majority of them were high T stage, like T4. So we looked at the genomic alterations after sequencing, and we showed that there was significant overlap with colorectal adenocarcinomas. So, but out of those 15, 11 of them had at least one genomic alteration in these different genes, which are novel findings, and these can be used for potential therapeutics applications. So in this cohort of 15 cases, you can see there were several of them which had the p53 missense mutations, stop gain mutations in these different genes. And this shows you the different histologies and the different clinical pathological features of this tumor. So the take-home message was, so for in this case, for example, CTNNB1 and APC mutations were restricted only to the enteric subtype. And you can see when we actually stained these tumors, some of them, this one had nuclear beta-catenin positivity, and these ones did not. And these were essentially APC or CTNNB1 alteration negative, which kind of shows to you why we did not see any nuclear staining in primary bladder adenocarcinomas of enteric type. This is the mucinous type, and in these tumors, we didn't see any distinct genomic alterations as compared to colon adenocarcinomas. So once again, FGFR3 and RAS mutations and APC, CTNNB1 and ID2 alterations were mutually exclusive between the primary and the high-grade cancers, as you can see here. So again, just remember this pathway. There are 2 pathways, the low grades and the high grades and the flat lesions. So in the context of the new WHO, it's easy to understand now why we have these 2 pathways and what is the significance of all these clusters that I showed you before. So this is a halftime view of football stadium in Columbus, Ohio. So this is the marching band of our football and during a football game. So let's look at a case. So this is a 34-year-old man who presented with abdominal pain and dysuria. A CT scan was performed. It showed a small nodule on the dome of his bladder. Cystoscopy was performed and it showed a 2 to 3 centimeter tumor at the bladder dome. So this is what we saw. Partial cystectomy showed bladder mucosa here. And this is an H&E, lesion protruding from the mucosal surface. It's lined by intestinal type epithelium. So within this lamina propria, there was desmoplastic reaction. And if you looked at it in the close proximity to the lesion within the bladder, there is a dilated cystic space, which you can see here. So this is the high power view. And if you go down to the stroma, you can see these reaction, desmoplastic reaction, and you can see which is extending into the muscle. So if you look at high power view, this is invasive cancer, which is arising from this villus adenoma. So this is the low power view of the muscle, the trochanter muscle, where you can see invasive cancer. And this is a stain, keratin stain. So you can see there is definitely invasive cancer arising from this villus adenoma. So this is a urachal adenocarcinoma associated with villus adenoma. So when we are sampling a bladder and you see what you think is a villus adenoma, go back and if you don't see an invasive cancer, go back and ask for more sections. Look at the histology more closely, and you will most commonly find invasive cancer in these patients. So here is a high power view showing invasive cancer, and it can be very easily missed because of all the significant desmoplastic reaction. So urachal adenocarcinoma is clinical presentation is very rare. Hematuria is the most common symptom, and usually these patients will also have cystectomy with umbiliectomy. So these are colonic type glands. This is so urachal remnant from these lesions arises and is only identifiable in a subset of cases. So you may not even see the urachal remnant. So how do you establish a diagnosis of urachal adenocarcinoma? The first is, where is the tumor located? It's usually in the bladder dome. Second is the background. You often don't see in situ carcinoma or glandular differentiation. And again, a thorough clinical workup looking for any other primary adenocarcinoma has to be done, because it's more common to have primary adenocarcinoma, more common to have metastatic adenocarcinoma in the bladder. So let's look at go back and look at the urothelial neoplasms. So within the invasive carcinomas, there are several subtypes that you will encounter when you look at the pathology of these tumors. So these are different types of urothelial variants, urothelial carcinoma variants. So let's talk about the micropapillary variant. This is a variant with high-grade cytological features, and you will often see tissue retraction in these tumors. So this is the micropapillary variant of urothelial carcinoma. And many of these tumors will express, which will have a mutation in HER2/neu, so which raises the possibility of targeted treatment using HER2 inhibitors. So this is a high power view of a micropapillary variant of urothelial carcinoma. More micropapillary urothelial carcinoma invading into the trochanter muscle. And so this is the other variant I want to show you. This is the nested variant. So you can see these bland, very bland looking nests, but they're invading into muscle fibers. You may not see a significant amount of cytological atopia. So this is the nested variant of urothelial carcinoma. Most of these have very bland appearance. There is some architectural complexity, and some of these may frequently invade into the trochanter muscle, as you can see in this case. This is the lymphoepithelial lymphoepithelioma-like variant. So if you looked at it low power, this looks like, this could present to you like a lymphoma. But this is a lymphoepithelioma-like variant, where you can see a prominent lymphoid infiltrate with other types of epithelial cells. So here are these epithelial cells admixed with the lymphocytes. These neoplastic cells contain vesicular nuclei, very prominent nucleoli, and numerous mitoses. So another picture of a lymphoepithelioma-like variant of urothelial carcinoma. And if you stain it with keratin, the lymphoepithelioma carcinoma is highlighted in the background of all these lymphocytes. So let's look at some cases. Okay, so how do we use immunohistochemistry? So I want to illustrate to you the use of immunohistochemistry. So there are two reasons to use IHC, immunohistochemistry, in bladder tumors. One is to differentiate reactive urothelium from carcinoma in situ. And the second is to confirm urothelial site of origin versus other primary tumors. So this is the table that I normally use. This is the workflow where we use CD44S, CK20, K67, P53, MIMICKER or race mace. And the goal is, if you see, for example, CK20 in the carcinoma in situ, it's transurethral and it's strongly staining. In a reactive urothelium, it's usually negative and only stains umbrella cells. So all these immunostains can help us separate a normal or a reactive urothelium from carcinoma in situ. Like yesterday, I had a case where from the outside hospital in the renal pelvis, it was called high-grade urothelial carcinoma. I looked at it, I thought this looks very reactive. So I stained this with a CK20, a CD44S, and I saw only umbrella cells were lighting up with the CK20 stain, which suggested to me that this was more reactive. So I called the urologist last night, and the patient was scheduled to have surgery today, and then the surgery stopped now because I think this looks more reactive to me. So after the seminar is over, I'm actually going to show it to another colleague and then call the urologist again. So this is how you kind of distinguish a reactive urothelium from carcinoma in situ. So here you can see carcinoma in situ, where you can see CK20 staining, strongly staining the entire transurothelial, and you can see high P53 expression in these nuclei. So on the left-hand side, you can see CK20 and P53 staining together, and this is carcinoma in situ. On the right-hand side, this is a reactive urothelium. So only umbrella cells are highlighted by the CK20. So together, these two stains can help you separate a reactive urothelium, which looks atypical, but it's not cancer. And if you called it cancer, the patient will get the wrong treatment. So let's look at this. So how many of you think this is reactive? So, if I showed this to 10 pathologists, 7 of them will say, this looks like there might be some cancer here, it might be dysplastic, or it could be reactive, right? So if you did an immunostain for CK20, only the umbrella cells will light up. So the final diagnosis will be this is benign, this is reactive. So CK20 is a really good marker to help separate reactive from neoplastic. But again, remember that based on the sequencing data that I showed you, if it's not the right phenotype, if it's not the right cluster, CK20 may itself be negative in these tumors. What about this lesion? So this looks more atypical. You have large nuclei. So my rule of thumb is I look at the lymphocyte in the lamina propria, and I compare the lymphocyte to the nucleus of the urothelium. If the nucleus of the urothelium is 5 to 6 times the size of the lymphocyte, then it's cancer. It's more likely cancer. So if you did a CK20 stain, this entire urothelium will stain with CK20, and this is a good way to distinguish cancer from reactive. The other places where you use markers is to separate urothelial cancer from non-urothelial cancer, such as prostate cancer. P63 is usually positive, high molecular weight is usually positive, CK7 is always positive, CK20 may or may not be positive depending on the cluster that I showed you, and GATA3 is again a good marker in these tumors. So GATA3 is a nuclear marker, it's positive in urothelial cancer, but it's also positive in breast cancer, but it's negative in prostate and squamous cell carcinoma. So this is the panel that I use to separate prostate cancer from urothelial cancer. If you had to only use two stains, I use a NKX3.1 marker for prostate cancer and a GATA3 or a CK7 marker for bladder cancer, or even a P63. So this is prostate versus bladder, and you can see these tumor cells are positive for P63, they're positive for high molecular weight keratin and GATA3. So this is the bladder cancer, which is mimicking a prostate cancer. So let's look at another case. 62-year-old man with hematuria, bladder mass. So this is what you see at low power. So it looks like cancer. This is what you see on transurethral resection. So if you looked at it, you know, like what would you think? What would be a diagnosis? Urothelial cancer. This looks like papillary urothelial carcinoma. There are some areas of calcification. So most people would not even. However, if you look more closely, you can see prominent nucleoli within these nuclei. So this, you know, with this kind of a morphological appearance, even though it's poorly differentiated, you should look at the history. Look at the history if this patient has prostate cancer. You should look at the serum PSA level. And then if you look at higher power, these nuclei are very pleomorphic. Generally, prostate cancer is not as pleomorphic. So if I asked you in the audience, what would you diagnose this? What would you think about, right? You would think about prostate cancer, you would think about bladder cancer, but based on this morphology, you might favor this to be bladder cancer. So what is your diagnosis? So if you stain this with PSA or NKX3.1, which is a prostate marker, all these nuclei are strongly staining with NKX3.1. So this is really, this is PSA, and PSA is also staining these cells. So this is prostate cancer, which is mimicking a bladder cancer. And I've seen a number of cases where stains were not done, and this was called bladder cancer because it was invading in the bladder, and the history of prostate cancer was not available, or maybe this was the first presentation of a prostate cancer which was involving the bladder. So let's look at a couple more cases, and then we can stop for questions and then move on to bladder cancer. So this is a patient with a bladder mass. A partial cystectomy was done, and this is what you see. So you see these almost look like nested looking urothelial tumor possibly. High power, you can see nuclei, and you can again see a nested appearance. This tumor is invading into the muscle. So if I showed this to you, what would you think about? What would be your diagnosis? So when this case came to me, this was called invasive urothelial carcinoma. So what are some of the steps? Are you satisfied with this diagnosis? So when I looked at it, it looked very strange. It looked, you know, my diagnosis was, could this be nested variant of urothelial carcinoma with very bland looking nests of invasive urothelial clusters? But I looked at it more closely. I thought this could be a paraganglioma of the bladder. You know, it looks like all these are nests. These could be sustentacular cells. So indeed, this is a paraganglioma. So paraganglioma of the bladder is rare. It accounts for less than 0.1% of all bladder tumors and about 6% of all extra-adrenal pheochromocytomas. So within the GU tract, the urinary bladder is the most common site, and it occurs more frequently in women than in men. So tumors, again, may be dysfunctional or non-functional or functional, But if you see nested growth pattern, if you see occasional clear cells, necrosis, pathologists may call this invasive urothelial cancer. But the key is, like, this is another case where we saw this type of morphology. And again, this was called invasive urothelial carcinoma. But this is another example of a paraganglioma. We did again, in this case, GATA3 was done. And GATA3 is a marker for bladder cancer. But many people don't realize it, but GATA3 can actually stain paragangliomas also. So this is a synaptophysin stain. This is a chromogranin stain. So this is a paraganglioma, which is mimicking like a urothelial carcinoma. So some of the features that you would see in paraganglioma can cause diagnostic difficulties, and it can be misdiagnosed as urothelial carcinomas. So these are some examples of paragangliomas which are staining strongly with GATA3, what they were called invasive urothelial carcinoma. So with this, I'm going to stop this talk, and then we will see if I have any questions for this talk, and then we can go on to the prostate cancer talk.
Dr. Anil, we don't have any question yet.
Okay, excellent. So
yeah,
I will go on and start the prostate cancer lecture. How are we doing with time?
Yeah, we are good with the time.
Excellent. So
yes.
Okay, excellent. So this is this is the lecture on prostate cancer. What I'd like to do is show you some of the new updates in prostate pathology, and I want to talk to you also about the new grade grouping that we use in prostate cancer. I want to show you some benign mimickers of prostate cancer. I want to show you some variants of prostate cancer. And I want to really focus on this complex cribiforming lesions of the prostate, which are problematic lesions. And if we have time, I will show you some challenging cases from my practice. So prostate cancer remains the most commonly diagnosed solid tumor in US men. According to American Cancer Society, about 191,000 new cases of prostate cancer in 2020, and about 33,000 men will die of prostate cancer. About 1 man in 9 will be diagnosed with prostate cancer during their lifetime. So it's critical to have early detection, it's critical to have early intervention, and this translates to improved outcomes. Some of these are established risk factors: dietary habits, lifestyle, race, ethnicity, genetic factors, family history, age. So the more as the patient grows older, men will likely to have prostate cancer. So let's look at the current classification of prostate tumors in 2016. This is a screenshot from the new WHO book, where you can see WHO classification tumors of the prostate. And if you looked at it, compared to the previous classifications, these are some new entities that were introduced into the glandular neoplasms or the adenocarcinomas. These include microcystic adenocarcinoma, pleomorphic giant cell, sarcomatoid, and also intraductal carcinoma and variants of ductal adenocarcinoma. You also have urothelial tumors, squamous tumors, and basal cell tumors. So it's important to understand the features that we use in formulating grading systems. So a number of grading systems have been introduced for prostate cancer. Some of them rely on nuclear morphology. Some of them rely on architecture. Some of them rely on overall grade. So, and some of them are composite of nuclear and architectural features, worst area versus weighted average. Overall, the goal is the grading system should really correlate with long-term tumor behavior. So one of the most powerful histological grading systems in pathology is the Gleason grading system. It was introduced by Dr. Gleason in the 1960s. It was more widely adopted in the late 1980s to early 1990s. It's a very robust system. It's very helpful in predicting disease outcomes. And it provides important data in management and treatment of these patients. It was recommended by WHO in 1993 and endorsed by the AJCC. So this is Dr. Gleason. And Dr. Gleason was a pathologist at the VA hospital in Minnesota. And in his earlier days as a pathologist, he used to make drawings of these different prostate cancer types. So, and he found 9 different pictures, which included the full range of histology in these 300 patients. And when urologists followed these 300 patients, they found that there was a strong correlation between Dr. Gleason's histological pictures and the patient's death rates and the cancer-specific death rates. So this resulted in patents, and this became a basis for the histological score, which was then eventually called the Gleason score. So this is the original drawing from Dr. Gleason. So you can see these different patents, which were then became the basis for Gleason's score. So and this has continued to evolve. So this is in 1966. This is in 1974. This is in the 2005 ISUP Consensus Conference. And you can see the different modifications is in 2005 Consensus Conference, we were still including these cribiforming lesions as patent 3, but now today in 2020, we call these patent 4. So as we have understood prostate pathology, as we've understood prostate cancer patients, this Gleason patent has continued to evolve. So today, majority of the cribiform carcinomas are Gleason patent 4. And so this is an example. And there are complex cribiforming glands. So, and we have new entities we should be thinking about, like intraductal carcinoma of the prostate. This is ductal adenocarcinoma of the prostate. So in this picture, you can see Gleason patent 3 and Gleason patent 4. And when you report these tumors, it's important to understand these different Gleason patents and its implication on patient care. So in 2016, a new grade group system was introduced and endorsed by the International Society of Urological Pathology and by the WHO. So in this is the more contemporary Gleason patent, where you have Gleason patent 3, 1, 2, 3, 4, and 5, where you have Gleason patents less than 6, 3 plus 4, 4 plus 3. So in this new grade groups, anything which is 6 is called group 1, anything which is 3 plus 4 is called 2, 4 plus 3 is actually called a separate grade group, and grade Gleason score 8 is called grade group 4, and 9 and 10 Gleason scores are called grade group 5. So we still use the Gleason morphology or the basis for classifying this as 3 plus 3 or 3 plus 4, but they are called Gleason grade groups 1 through 5 now. And grade group 1, which is only individual discrete well-formed glands, so you can actually draw a line around these glands. Grade group 2 is 3 plus 4, predominantly well-formed glands with a lesser component of poorly formed glands. Grade group 3 is 4 plus 3, so these are predominantly poorly formed fused cribiforming glands, so more 4, less 3. Or the next one is grade group 4, this is any combination of 4 plus 4, any combination of 8. So these are generally all poorly formed fused cribiforming glands. And finally, grade group 5 is you don't see any gland formation, or you see necrosis, and you see poorly formed fused cribiforming glands. So we did a study where we actually followed 20,000 patients. So this is where I used to work at the University of Pittsburgh, and these were patients that I contributed to the study. So there were 5 different hospitals, which were total was 20,000 patients. So when we followed these patients for probability of recurrent free progression, we could separate these 5 patients into 5 groups, grade group 1 to grade group 5. So the point is, biologically, these tumors behave very differently, and it's important to understand that in the context of the Gleason score. So the 5-year biochemical risk-free survival was correlated highly with the grade groups in these 20,000 plus patients. If you looked at the biopsy meta-analysis and the frequency, again, you can see the recurrent-free progression. So you could easily separate these patients out and the outcomes. So when you call someone 3+3 and you assign it a grade group 1, that patient will likely to have a very high probability of recurrence-free progression. So we also looked at patients with radiation, and we were able to again separate them out into different groups, grade group 1 to grade group 5. So why do we need these grade groups? What is important? Why do it? Why do we introduce another grading system when you already have the Gleason grading system? So one important point to understand is when you call something grade group 1, this has an excellent prognosis, no metastasis. It avoids the issues of Gleason score 6. So when you tell the patient you have cancer, prostate cancer, and it's his Gleason score 6, and they will ask you, oh, 6, what is 6? It's 6 out of 10. So it sounds pretty bad, but it's really not. So grade group 1 is more realistic. It gives the patient the impression that they have a low-grade cancer, and most of the time they will have an excellent prognosis, no mets. Grade group 2 is very good prognosis, rare metastatic. So previously, in some classification schemes, 3+4 and 4+3 were lumped together, but they are not. They should not be lumped together because they are very different tumors. Grade group 2 is very good prognosis, rare metastasis. Grade group 3 has a greater prognosis, greater chance of metastatic cancer. Grade group 4 is much better prognosis as opposed to combining 8 through 10 that we used to do previously. Better prognosis than 9 and 10. And you don't, when you put someone in grade group 5, you don't need to distinguish if it's 4+5, 5+4, 5+5. So it's really becomes easy to communicate these results to the patients. So let's talk about what are some of the challenges in prostate cancer diagnoses. So there are, as we look at patients, we're seeing more and more small foci of cancer. We're seeing small foci of atypical glands. We also have MIMICKERS of prostate cancer, which include many benign lesions. We also have many variants of prostate cancer, which can look like benign, which can look benign. So in this picture, there are 4 different patients. If I ask you to classify one of them, which is not cancer, this is not cancer. In this case, there are 4 different patients, and if one of them is cancer, 3 of them are not cancer. But as you can see in morphology, it's very hard to just call them confidently cancer versus not cancer. Some of them easier than others. So this is cancer. This is prostate cancer. So common feature of false negative variants are unusual histological variants. So you call them falsely negative, or benign mimickers. So you call them falsely positive. So you're overcalling them as cancer, but they are not. So let's look at some examples. So this is a patient with a prostate cancer needle biopsy. You have these 2 clusters of cells. They look very amphiphilic, look very dark. There might be some crystalloids in the lumen. If you did an immunostain for basal cell markers, both of these clusters are negative for high molecular weight cytokeratin. If you did a Reisme stain or MIMICKERS stain, they are strongly positive. So this is prostate cancer. These are 2 small foci of prostate adenocarcinoma. So features that I find very helpful in cancer versus benign glands are nuclear, cytoplasmic, luminal, or architectural. Within the nuclear features, presence of nucleoli, enlarged nuclei, mitotic figures. Within the cytoplasm, darker cytoplasm, amphiphilic cytoplasm. sharp luminal border, lack of pigment. And within the lumen, if you see any mucin, if you see any pink secretions, do you see any crystalloids? And architecturally, do you see mucinous fibroplasia? Do you see perineal invasion or glomerulations? So all these are features that I use to call something cancer versus benign. I do not order a lot of immunostains on prostate needle biopsies because if you are really paying attention to the morphological features, you don't need immunostains most of the time. So this is an important criteria, looking for nucleoli within the nucleus. So in this case, this gland shows very prominent nuclei and also shows true mucin in the lumen. In this, you can see crystalloids within the lumen, maybe some pink secretions next to it, very dark cytoplasm, sharp edges. In this picture here, you can see these dark glands, 1, 2, 3, 4, all these dark glands, this dark gland. These are all prostate cancer. At high power, you can see prominent mucin in these, very prominent nucleoli in these, and crystalloids in these glands. So what are some of the benign mimickers? So I'm going to talk to you about a few of these benign mimickers. So these can be anatomical structures like seminal vesicles, Cowper's glands, paraganglion. All these are normally present in the benign prostate. But in the context in a prostate needle biopsy, they may look atypical. They may mimic cancer. Atrophy is another mimicker, which can be partial or simple. Inflammation can look alarming, like malacoplakia, granulomatous inflammation, metaplasia, like mucinous metaplasia, nephrogenic metaplasia, prostatic hyperplasia, basal cell hyperplasia, adenosis. All these are mimickers of prostate cancer. So we did a study where we looked at several hundred, 567 prostate needle biopsies, which were benign. And we looked at the most common benign mimicker of prostate cancer. And the most common benign mimicker of prostate cancer was partial atrophy. So partial atrophy is this lesion where you see prostate glands with scant cytoplasm, but it appears very pale at low magnification. And a good way to think about it, it's almost like the nucleus size is the size of the nucleus. So nuclei occupy almost the full cell height, and the cytoplasm is similar to the cytoplasm of the surrounding benign glands. So if you look at this lesion here, this is partial atrophy. So look at all these different clusters of glands. You can see this was the one I showed you before, which was called prostate cancer. So this case came to me in consultation, and it was called adenocarcinoma. And if you look at it more closely, you do see some pink secretions, you do see some blue mucin, but you don't see prominent nuclei. And some of these cytoplasm is very much the same size as the nucleus. This is another example of partial atrophy, very pale glands in the background. The nucleus is the same size as the cytoplasm. So here you can see, and they have pink secretion. So when you're looking at it at low power, you think, oh my God, this looks like prostate cancer. And you start to get worried. But the key is the nuclei are maybe slightly enlarged, may appear slightly irregular. You may see some blue mucil, but you have to be aware of this lesion. And the other lesion to think about is adenosis. Adenosis is where you see back-to-back glands, where you see some crystalloids. But if you look closely, you can see basal cells in these glands, which tells you that this is not cancer. And if you look at this, some of these glands are negative for basal cell markers, but right next to it, others have basal cells. So when you want to call something cancer, and you did a stain like this, and some of them are staining with basal cells, others are not, that should back you off. You should not call it cancer, because this is not cancer. This is adenosis. So another example of adenosis. Also radiation atypia, when patient is radiated, prostate is radiated, you can have significant atypia. The nuclear can look atypical, they can have hyperchromasia, but this is not cancer. This is radiation atypia. So at higher power, these glands can look pretty atypical with large pleomorphic nuclei, hyperchromatic nuclei. So these are some benign glands following radiation atypia. So all this is radiation atypia. Again, angulated glands with hyperchromatic nuclei. This is radiation cancer, radiation treated prostate cancer. So number one, you should not grade this. So you would still see some blue mucin, but a lot of these nuclei have vacuolation in them. You can see, but they don't have all the atypical features that I talked about. So these are benign glands following radiation as compared to radiation cancer. So this is cancer which has been radiated, prostate cancer. And you do not need to grade these. You do not need to assign a Gleason grade to these cancers which are radiated. So let's look at another case. So this was actually a patient that I saw biopsy from, 62-year-old man with a PSA of 3.61. This is what you saw on the biopsy. So you have these glands which look like, there's some crystalloids in it. It looks like cancer. The outside pathologist called this prostate cancer. They gave it a Gleason score 3+3. The patient was scheduled for surgery at our hospital. So we have a process where all biopsies or all outside biopsies and outside pathology is reviewed a second time by a pathologist at our hospital to confirm the diagnosis. So I looked at it. It looked like cancer to me, but I was just not sure about all these back-to-back glands. And I wondered, could this be adenosis? This looks like, could this be adenosis? So when you look at higher power again, you can see some basal cells in some of these glands. Even though they have pink secretions, they have prominent crystalloids, this could be a benign mimicker of cancer. So I ordered a cytokeratin 903, which is a high molecular weight cytokeratin. So many of these glands were completely negative, which fits the diagnosis of cancer. But similar appearing glands appear to have basal cells. So when you see this, when you want to call this cancer, why isn't this cancer? They look very similar to each other. The other thing which kind of threw me off was AMCAR or racemase, which is a marker which is preferentially expressed in cancer, was strongly positive in these glands. But overall, we looked for TMPRSS2 translocation, which is seen in about 60% of prostate cancers, and there was no translocation. So taken together, I called the urologist. I told them this is not cancer. This is a benign mimicker of cancer. And I recommended a repeat biopsy. So 6 months later, the patient had another biopsy, showed the same thing. And 10 years later now, this patient continues to do well. If this patient was called and was treated as prostate cancer, maybe they would have had surgery, and this is a surgery they did not need. So the point is, there are many benign mimickers of prostate cancer that you have to be aware of. This is a 76-year-old man with BPH. So transurethral resection was done. Again, similar findings. You have in BPH, you have these type of glands which have basal cells, very prominent basal cells. So again, this is adenosis. If you did 903 stain, they stain these cells to show you the basal cells. But some of these glands are negative. So by itself, negative staining with basal cell markers does not mean this is cancer. So you have to be very careful making that diagnosis. Histological features which are more common in mimickers of adenocarcinoma are atrophic cytoplasm, merging with benign glands, corpora amylaceae, inflammation, pigment, adjacent prostate intraepithelial neoplasia. So let's look at a couple of the variants of prostate cancer. So this is a 60-year-old man with high PSA, and on biopsy you see this type of finding, where you see large pleomorphic giant cells. So when you look at this, you might wonder, is this really prostate cancer? Is this a sarcoma? Is this a metastatic cancer coming from somewhere else? So we did a stain for cytokeratin and it was strongly positive. We did a stain for PSA, it showed some staining. So these are some examples of different morphologies in these type of cancers, where you have large pleomorphic giant cells, like this. So this is a pleomorphic giant cell adenocarcinoma of the prostate. It's fairly rare, and I only make the diagnosis if I see really prominent pleomorphic component, which is greater than 5 to 10% of the entire case. And in some cases, you might see conventional 3+3 cancer or 4+3 cancer. More often than not, these patients have no radiation treatment, they have no prior therapy. So this is just a very unusual variant of prostate cancer that you have to be aware of. And you don't assign it a Gleason grade. So 2 more minutes. I know we're running against time. I want to show you some of these problematic complex cribiforming lesions. These include ductal cancer, intraductal carcinoma, high-grade PIN. So this is a typical cribiforming lesion. And if I ask you, what is the diagnosis? You might say this is prostate cancer 4+4, which is not incorrect. But you have to be aware of the spectrum of complex cribiforming neoplastic lesions that you can encounter in the prostate, ranging from PIN to intraductal cancer to invasive cancer. So PIN, we can easily make the diagnosis. If you stain this with a cocktail, they have basal cells, they stain strongly with racemase. So a diagnosis of PIN is not very challenging, but this is ductal adenocarcinoma, which again by itself is not a problematic diagnosis. This is a subtype of adenocarcinoma with large glands. It almost looks like endometrial cancer. So another example of ductal cancer, tall columnar cells, looks like embryonal cancer. This is again different patterns of ductal cancer. So let's look at this one case, 49-year-old with high PSA, and you should see this cribiforming complex lesion. You look at it, you think you want to call it cancer, but as I looked at it more carefully, I thought, could this be intraductal cancer? So I did a stain for high molecular weight cytokeratin, and all of these have basal cells. So inside the duct, you don't see any basal cell staining, but around the duct you see strong basal cell staining. So this is intraductal cancer. So I want you to be aware of intraductal carcinoma, because these are malignant epithelial cells filling large acini. They can have a solid or dense cribiforming pattern, and they have marked nuclear atypia. Nuclei are 6 times the size of normal, and you can see non-focal comedoid necrosis. But more importantly, the basal cell layer is preserved. So by definition, this is not invasive cancer because there is basal cell present. So this is an example of intraductal carcinoma. So you can see this cribiforming lesion, large nuclei, 6 times the size of a normal nucleus. And if you did a PIN4 stain, you can see strong basal cell staining in the periphery, but no staining of basal cells within this duct, and strong racemase staining. And in the periphery of this, you see more conventional cancer, infiltrating cancer. So whenever I see a lesion like an intraductal carcinoma, I put a comment in my report saying that intraductal carcinoma is identified. This cancer is almost always associated with a high-grade cancer on a subsequent resection specimen. So with this, I'm going to stop. I know we are running out of time. I really appreciate your attention and listening to this lecture. And I hope to visit you guys in come to Lahore and visit you and visit your hospital. So thank you for inviting me, Dr. Hussain. This was a really exciting uh, session for me. Thank you. And if
Thank
you
you
have
very
any
much.
questions, I'll be happy to answer them.
Yeah, thank you very much, Dr. Anil, and for all these enlightened and informative lectures. So we have few questions. So the question number one is, in the partial atrophy can show MICR positivity. It can even lose its basal marker and can show prominent nuclei. How to deal with this situation when dealing with a small biopsy?
Yeah, so excellent question. So with partial atrophy, if you pay attention to the morphology, where you do see, like I said, most of the time you will see pale cytoplasm. Most of the time you will see cytoplasm which is the same size as the nucleus. There may be some nucleoli, uh, and they can be somewhat prominent, but they will lack the other features of cancer like amphiphilia. They will generally lack the lumen contours, the smooth contours. If you stain them with basal cell marker, they can lose their basal cell marker, but in general, you will always find one or two nuclei, one or two cells with some basal cell staining. So not 100% of the basal cells will be lost in that focus. And the Amicar staining can be can be can be positive, but in my experience, it's only positive in about 15 to 20% of the time. So what I usually do is I get levels and I repeat the immunostain one more time. And I look at the patient's PSA level. I look at the surrounding other biopsies. And most of the time I don't even do immunostains anymore. If I think it's partial atrophy, I let it go because I know that a subset of these patients will show lack of basal cell staining.
Okay, so another question, how can we differentiate nested variant of urothelial carcinoma from benign mimickers morphologically?
Yeah, so very good question. So the nested variant is a very challenging lesion. What you would do, the most common benign lesion that you can is in your differential is a prominent von Brunn nest proliferation or cystitis cystica. So in patients with prominent von Brunn nest, particularly in ureter lesions, you will see very prominent von Brunn nests. You will not see nested variant. You would see some atypia occasionally. You might see some mitotic figures. You might see some nuclear enlargement. But if you're not absolutely not sure, what I've done in the past is I've actually done a cytokeratin 20 stain, and it'll highlight the neoplastic cells in the nested variant. It'll also, you can do markers like Ki67 or P53. So compared to benign von Brunn nest, you will see a higher expression of these markers. And again, if you go down to the base of the lesion, like where the lesion is ending and there is lamina propria, you will see slightly more nuclear atypia generally. Um, so it's a very challenging lesion, and thank God you don't see it very frequently. But you have to um, just rely on your morphological features. You have to occasionally do immunohistochemistry if you can. Some people actually have done fish studies. So we have a fish test Eurovision that you can run on these lesions as well. So those are some of the things that I do to help me make those differentiations.
Okay. Uh, Another question, how to differentiate inverted pattern from nested variant in the absence of detrusor muscle?
So inverted pattern of urothelial carcinoma, right? Is that the so you can have uh, non-invasive urothelial carcinoma, which is papillary, but it has a prominent inverted pattern. From nested variant is sometimes it's very challenging because you don't see the exophytic component, you don't see the luminal papillary component, and you all you do is you see this. The good news is generally if it's inverted and it's low grade, it doesn't really, the nests do not extend very deep into the lamina propria, and they're always connected. So what I do is normally take multiple levels, H&E levels, and examine them. And if I see discrete nests away from the surface, I would favor that to be a nested variant of urothelial carcinoma. And oftentimes you will see a good evolution from the surface all the way to the base when it's inverted. So you don't see a difference in morphological appearance, and you don't really see a differentiation in the in situ component.
Okay, another question for you. So in the high-grade Gleason tumors, is it required to report intraductal carcinoma?
So it's not necessary. It's not necessary. You don't, like, if you are absolutely sure that if you only see cribiforming lesions, right, and you don't see an invasive cancer around it, you don't see pattern 3 cancer, then your differential is this 4 plus 4 cancer? Is this all 4 plus 4 cancer versus all this is intraductal cancer? So that's the only differential you have. And if you really go back to the cases that you've diagnosed in the past and you did a basal cell marker on some of these things, you will see that some of them had an introductory component and you didn't call it. The good news is patients who have an intraductal cancer on a subsequent resection will very with a high likelihood will have high grade cancer, will have 4 plus 4 cancer. So it's not absolutely critical. It's only critical when you have three cancer and you have one cribiforming lesion and you want to call that 3 plus 4 or 4 plus 3. That's when you really have to differentiate. But if you have back to back what looks like 4 plus 4 or 4 plus 5, then it doesn't really make a difference.
Okay, and I think the last question. Are you doing molecular subtyping of urothelial carcinoma in your setup?
Not on a regular basis. So we do occasionally we do fish studies, we do Eurovision in some of these lesions. We are now starting to see requests from oncologists to do PDL1 testing on urothelial carcinomas. We are starting to see some of these are getting sent out for molecular prognostication, looking for like HER2 expression or other things. But we don't routinely do molecular subtyping of urothelial cancer. Occasionally, I sequence the adenocarcinomas of the bladder just to just to see if they are the same as a colon adenocarcinoma or not.
Okay, thank you very much, Dr. Pravani. I think this is it. No more questions. So thanks for your time. And both day, your time was early in the morning and you are willing to join us. And I think we all are honored that you gave us your very precious time. And next year, I hope you will be physically here in.
Yeah, I hope so. I hope, I told my parents I will visit them in Karachi and then come to this symposium and, so maybe next year.
Yeah.
Yeah, I would really like to. I miss Pakistan.
Okay. Thank you very much.
Thank you so much. Thank you for all the attendees for listening to the lecture. And if you wish to get a PowerPoint copy of my presentation, I can email it to Dr. Hussain and they can be transmitted to the attendees.
Okay. Of course.
Thank you so much. Have a good rest of the conference.
Thank you very much. Thank you. So this is the end of the pathology sections in this year's symposium. And I like to thank all the participants because without the participant, every conference and every lecture would be just a skeleton, because they are the real flesh of the any lecture or any meeting. So, and I like to thank the entire team of the scientific program, especially Dr. Sumaira, Dr. Asad Pervez, and my hat is off for the entire IT team because their relentless efforts made this meeting a success. So, moreover, my own department, and especially I thank Dr. Sajid Mushtaq, Dr. Osman Hassan, and the entire consultant team. They were very supportive for me, and they helped me a lot. And especially our administration, Dr. Asif Loya, and lastly, one and only Dr. Asim Yusuf. Thank you very much.